experts who have joined and given us this opportunity. And on behalf of EMCURE, I'm really thankful for providing us this opportunity and your valuable time on Saturday evening. I also would like to thank all the doctors who are joining in large numbers and the people who have already joined. Just a 5 minutes delay in the starting of the program, but we are all good to go now. So without further ado, I take this opportunity to initially introduce our eminent faculty who we have with us today. To begin with, our moderator of the program, Dr. Rajesh Badani, sir, who has been mentor to many people. And I personally have gained a lot of insights over the years since I've started my pharma career as well. Sir is a senior consultant cardiologist who is working in Aditya Birla Memorial Hospital at Pune. I welcome you, sir, and thank you, sir, for your time.
Thank you, Anu.
Please also join me in welcoming the eminent panel, which comprise of Dr. Atul Abhyankar, sir, who is a senior interventional cardiologist from Surat. He's working as a director, interventional cardiology at Mahavir Heart Institute. Thank you so much, sir, for your time. Dr. Praveen Kahale, sir, who is a senior interventional cardiologist from KDA Hospital and Medical Research Institute from Mumbai. Dr. Manoj Dureraj, sir, who is again an eminent cardiac surgeon. He is director, Marian Cardiac Center at Pune. And also we have Dr. Rutvik Trivedi, sir, who is again a very dynamic cardiologist from Anand in Gujarat. He was working as a senior interventional cardiologist at Zydus Hospital. So I welcome all the eminent faculty for this program, and we look forward for your valuable guidance. The agenda today, in the next 50 to 55 minutes, we look forward to get insights from the experts on the topic of RAS blockers, how they have evolved in the area of post-MI space. Needless to mention the age-old 1990s trial of SAVE to the recent Paradise MI trial of ARNI. And we are trying to find out, do we have a verdict for which particular patient, which is the best RAS blocker that can be used. So without further ado, I would now hand over the session to Dr. Badani, sir, for his moderation and for the clinical insights. And I request our audience, if there are any queries or any feedbacks, please post them in the chat box so that when we get the opportunity, our experts will share their views on your queries. So with this, over to you, sir.
But basically, this program I've been a part of it over the past many years. And I think this topic is also very close to my heart in terms of the role of ACE inhibitors post-acute AMI. And I think after the ARNI has come into the picture, we probably have a lot of things to discuss whether these patients of post-MI, mind you, we are not going to be discussing the chronic heart failure subsets. We are going to discuss patients with acute AMI. So that could be obviously unstable angina, STEMI, non-STEMI, those subgroup of patients is what it is. And if these patients, what is the role of ACE inhibitors and or ARNI? When should you use? What should we use? Which drug should we use? What data do we have? We'll probably try and discuss in the subsequent 45-50 minutes. And we have multiple experts from across the field, from a cardiac surgeon to a young interventionalist, to a seasoned interventionalist, to a very senior consultant. So, and that too across the board from Gujarat to Pune and Mumbai. So we'll have a varied clinical exposure or experience also as to how we should, use this molecule to our appropriate use, as well as to the audience. And what is the evidence exactly is also what we'll be trying to cover up. So I think with this, we will start. And, we'll probably initially take you through some data on ACE inhibitors, and then we will have some interactions with the consultants in the course of time. So I would request all people who have questions, please put them in the chat box. Till the end, we'll probably try and cover up as much as possible. So thank you, and I think looking forward to a good meeting. Anup, you can, I think, start with the presentation.
Ashish, will you be sharing the screen?
Sir, visible?
Yeah, visible, visible.
Visible. Just make it full screen
Full
and we are
screen.
good to go.
Okay, so I think we are going to be discussing RAS blockers in acute AMI from the SAVE to the Paradise MI. That is basically the first trial of ACE inhibitor of SAVE trial, and Paradise MI, which has been the latest trial in which probably an ARNI was compared. So do we have the verdict? So this is what we want to probably try and gather from the audience. Next slide, please. So post AMI, we already know that ACE inhibitors were the first ones to be tried. Then came ARBs, and then came ARNI. And then what do the current guidelines suggest is what we'll probably try to discuss. Next slide.
I think Badani sir might have got some connectivity issue. I see that his screen got frozen.
You want to call him up and check up?
Yes, sir. I'm doing that only, sir.
He joined. He joined. He joined.
He has joined.
A major connectivity issue on that side.
Yeah.
Somebody can talk and continue.
Anu?
Yes, sir. We are able to hear you, sir. I think some.
I think there is an issue with the connect. I'll probably go through my cell itself. Can you just now go ahead with the slides? I think we'll go
Yes, sir.
quickly over. Sorry for the.
Also, you can stop your video, sir. In
Yeah,
case,
yeah. You can stop a video. The bandwidth might increase, Dr. Badani.
Yeah, but here it's just getting disconnected. That's the only issue. But I'll try my best. I'm now on both the things. Let me see. Go ahead. You can probably get the presentation on screen, I believe.
Is there, sir?
Yeah, sir. It's already there on the screen, sir. In case if it is visible to you, sir. Sir, you're mute, sir.
Sorry. Now it's
Yeah.
not visible to me.
Okay.
Why is... Yeah, now it is. Perfect.
Okay.
All right.
Great, sir. Great.
Fine. So I think we'll be talking about the ACE inhibitor post-AMI trials, which was the SAVE, AIR, and the TRACE trial. The SAVE trial, in which, which was in 1987 to 1991 for captopril trial. Target dose was 50 TDS with 2,200 patients. 3 to 16 days post-AMI, this drug was used, and EF below 40% was the inclusion criteria. The age group was between 20 to 80 years. Average follow-up was 42 months. AIR trial was the first ramipril trial between 89 to 92. 5 milligram twice a day was the target dose, and 3 to 10 days post-AMI was the duration of starting. And patients with evidence of clinical heart failure or radiographic were included, and all patients were above 18 years of age. The duration was 15 months. Trandolapril was between 1991 to 93. 4 milligram once a day was the dose, and 1749 patients, and 3 to 7 days post-infarction. And echo evidence of LV systolic dysfunction below or equal to 35% were included, and the duration was 24 to 50 months. Next slide, please. Now, say we've already discussed, so captopril definitely showed 19% mortality reduction and 20% reduction in recurrent MI. The cavity dilatation means there was significant remodeling which was noted in this trial, and this benefit occurred equally in patients who received lysis plus beta blockers and in those who did not. That means ACE inhibitor with without beta blockers independently had a remodeling effect. Next slide, please. AIR trial was obviously acute MI, transient heart failure, day 3 to day 10, and ramipril showed 27% reduction in mortality and 19% reduction in the rate of MI and stroke at 6 months. So this was also a very, very good landmark trial which proved the impact of ramipril in patients with acute myocardial infarction. Next slide, please. AIR extension was obviously the study with 600 patients who participated in the AIR trial. 42 months to 59 months was the follow-up period, and benefit effects of ramipril started early with heart failure sustained over 3 to 4 years despite discontinuation of medication at 1 year, and relative reduction was 36% and absolute reduction of 11%. So this showed that there was a sustained effect of a drug if it was used over a long period of time, which translated into remodeling as well as mortality benefits. Next slide, please. TRACE was the Trandolapril study in which anterwall MI with wall motion index less than 1.2 between 3 to 7 days and follow-up was 24 to 50 months. And result was 25% reduction in mortality, 15% in recurrent MI, and 20% reduction in sudden cardiac death. So this also told us that definitely there was great benefit which was there in this subset of patients. Next slide, please. So other evidences of ACE inhibitor post-EMA was ISIS-4, GC3, and CCS1, where you had 50,000 plus, and GC it was 18,000 patients, and CCS1 was 14,900 patients, and all showed that captopril reduced 5-week mortality, lisinopril after 24 hours, effective mortality reduction, and ventricular dysfunction impact. Anterwall infarction patient captopril treated also found to have lower mortality. So in a short term, intermediate and long term, we have data of ACE inhibitors with different drugs, which probably showed great benefit post myocardial infarction. Next slide, please. So now coming to ARB, next slide. What data do we have about ARBs which is there? So we already know that Optimal and the Valiant trials and the post-MI2 trials, in which one was losartan and second was valsartan, and ischemic etiology in both 100%, and EF below 35 in Optimal and below 14 Valiant, and mortality there was no difference at 32 months and no difference at 24 months. So even after 2 to 3 years, there was not much benefit seen in these two trials. Next slide, please. When we talk about the Optimal trial, which is there, with this, there was no significant difference in total mortality in favor of captopril. ACE inhibitors should remain the first choice of treatment in patients after complicated acute MI, and losartan cannot be generally recommended in this population was probably the conclusion of the Optimal trial. Next slide.
Recording in progress.
Coming to the again, mortality from any cause, similar in all the three treatments, captopril, valsartan, and the third was captopril plus valsartan. And the rate of secondary endpoints of death also was similar in the three groups. Next slide, please. So definitely we are very clear that the ACE versus the ARB trials, ACE was far superior. So I think we'll now get the panelists into action. I'll ask Dr. Praveen that ACE versus ARB, what is your preferred RAS blocker in ACS? Whether revascularization was performed or not to get. So imagine a person with an ACS is on medical management versus intervention done. What are your choices? You use ACE inhibitor or an ARB?
Yes, definitely we do use ACE inhibitor as a first choice of drug or a RAS blocker in an acute coronary syndrome.
And what is, even if a patient has not been revascularized, also probably ACE would be your first choice?
Yes.
Okay. Dr. Rutvik, your comments or anything that different do you follow in your clinical practice, or any evidence do you have or anything that you would like to comment on?
Yeah, first of all, it's a great discussion, and what slides you have shown.
The voice is lost.
Rutvik sir, we lost your voice.
I think he's there, but I think voice
he's
cannot be heard.
correct, sir. He is connected, but I think maybe we'll jump to
Okay,
the.
can we go to the next point here? Okay, so I think Dr. Abhyankar will imagine a patient who is already on ARB for hypertension and gets an MI. What is your choice? Would you switch the drug to ACE inhibitor, or you would continue an ARB in this patient?
I mean, if you look at the data that you showed in general, maybe it is ACE inhibitor is somewhat superior, but there is no data to suggest that whether switching from ARB to ACE inhibitor is going to really change anything. So, as a matter of fact, we always compare ACE inhibitor, ARBs, and in a debate, it's all right to pick a winner. But actually speaking, it's not necessary. This is not a zero-sum game, and that there has to be a one winner and one loser. So I think I would not want to change if the patient is on a stable dose of ERB. And if patient is doing all right, I would not necessarily want to change to ACE inhibitor if the patient is on ARB.
Okay, Dr. Manoj, your take on this, and then I'll probably
I
give you
think,
the concluding stuff.
yeah, I would go for the ACE inhibitor. I would put my bet on the ACE inhibitor because there are a lot of mechanistic activity which happens in terms of LV volume, end systolic and diastolic volume indices when you look at the ARB in the studies which you have already showed. And various, ACE inhibitors like captopril, lisinopril have clearly shown that by starting it from the second or to the 8th day post MI, you get a beneficial effect over the long term. It's not a short-term benefit, it's a long-term if the patient continues. So I would put my weight with the ACE inhibitor, especially ramipril, when we look at having a post-MI situation, especially in acute situation, of course.
Yeah, so I think both of you have put your points. Now, the only thing with Dr. Atul's thing would I would just little modify it is that imagine if a patient is on a telmisartan or an olmesartan, imagine for his hypertension, and he gets an MI, then definitely we know that post AMI LV dysfunction, there is no role of a telmisartan or olmesartan to be used in an acute AMI. Because again, we know these are not the drugs to be used in that subset. You probably, if at all a patient has been on losartan, again, we know the data from the optimal trial that it was not really a great benefit. So maybe if you would want to continue, maybe I think it is your take on that, but at least switch Olmi to the losartan subgroup which is there. Or if at all you're able to push them to your ACE inhibitor subgroup, probably that data already we have shown it, and what Dr. Manoj mentioned very clearly, that the remodeling benefits as well as the mortality benefits are far more. So maybe sometimes this we call it as, de-escalation from an ARB to an ACE post AMI. But somehow or the other, we've been doing that in our practice. But I think if Dr. Atul wants to continue, a losartan would be a fine drug, but not at least the telmi or the olmesartans, which is there, I believe. Can we go to the next slide, please? Okay, now the discussion of ACE ARB we already have discussed with the trials. Now let's talk about ARNI. And I think the most important trial that we would want to talk about is Paradise MI. Next slide, please. So as we all know, Paradise MI was basically a comparison of ARNI with ramipril in patients with acute MI. These were the Paradise MI, which probably was the first trial for ARNI in post-MI settings. Next slide, please. Now the data was 0.5 to 7 days with ejection fraction below 40% and or pulmonary congestion plus any risk enhancer more than 70 years, diabetic prior MI, atrial fibrillation, Killick class more than 3, STEMI without reperfusion, EF below 30 were included. And the target dose obviously was 200 milligram BID of valsartan, ARNI versus 5 milligram BID of ramipril, and almost 2,800 patients in both the arms were taken. And median follow-up was 23 months. Primary endpoint was CV death, hospitalization, and outpatient development of heart failure. And secondary was CV death or first heart failure, hospitalization. Next slide. So in this, everybody was of the strong impression that like the paradigm HF, here ACE inhibitor will be beaten hands down to ARNI. And here in India, we had highest number of patients, almost 330 patients, which were there from our country. Next slide. So we had a little bit of a representation which was there in the trial though. So profiles were literally similar. Ejection fraction in the tune of 35 to 37%. People are very symptomatic. Killick class 2 more than 2 were in almost 60%. And patients were already on beta blockers, aldosterone antagonists. Almost in 80 and 40% of these patients were there. And they were on DAPT and statins too. Next slide, please. And they were already on ACE inhibitor or ARB in 78% in the ramipril and ARNI. So it means these patients were on these drugs and they were shuffled across to the ARNI in the ARNI group. Next slide, please. So what was the result is in the ramipril, which is the blue line, was 373 events and 338 in the sacubitril valsartan. But when it talks about hazard ratio, it was 0.9, confidence interval of 0.78 to 1.04, p-value of 0.17, which probably did not reach statistical significance for the primary endpoint or primary outcome. Next slide, please. Again, the all death when we talk about 0.88, 213 in the sacubitril and 242 in the ramipril arm. Again, 0.88 hazard ratio, not statistically significant, p-value 0.16. So basically, ACE inhibitor was considered non-inferior or at par as ARNI, and ARNI did not prove the superiority as compared to the ACE inhibitor. Next slide, please. So summary did not result in ARNI did not result in a significantly lower rate of CV death, heart failure, hospitalization, or outpatient heart failure requiring treatment. Pre-specified observation of reduction in both reports of primary composite as well as in total agitated events support incremental clinical benefits of ARNI. Safety and tolerability of ARNI in this AMI was comparable to that of ACE inhibitor. So this is something, the second point which we'll come to, we need to understand that there was an incremental clinical benefit which was noted in the ARNI subgroup because it was a 23-month period follow-up which was there. Next slide, please. So Paradise MI, what did it tell you is ARNI doesn't surpass ACE after acute MI, makes me question the benefit of ARNI which was there, and sacubitril can't beat ramipril patient. This was probably the discussion which went through different places. Next slide. And sacubitril did not outperform. These were the next slide, please. Okay, so I would rather here take almost every panel's view on the first point and the second point separately. So let's start with the first point. Let's start with Dr. Praveen. That based on the primary outcome, what do you feel, advise, imagine after this trial that post-AMI patient, would you still consider that you would use an ARNI or would you consider continuing ACE inhibitors in your practice?
I think if patient is hypertensive, it's a large MI, patient is in heart failure, and there is an opportunity that patient would tolerate ARNI, I do use ARNI frequently in this type of population.
Okay. Others you continue ACE inhibitors, correct?
Yeah.
Okay. Dr. Abhyankar will take you, and then Dr. Ritvik, and then Dr. Manoj, so that you know see. Yes, sir. Your view, what do you do in your clinical subsets who are post AMI? After the Paradise MI, has your practice changed or you're doing the same? Is Dr. Abhyankar there? Okay, Dr. Ritvik?
Yeah, sorry, I was on mute.
Yeah, no problem. Go ahead, sir.
So, if I may, I would want to first comment on the Paradise. My choice would be ARNI to start with, but I would want to comment on the Paradise MI outcomes. See, when we say that it did not outperform, right, but it still numerically was better than the ASN. That's one. Second, it was on the preset non-inferiority margin of 15%. So the non-inferiority margins are obviously calculated on the basis of previously available statistics, and it is not something of a necessarily a figure which is so accurate. So one is the previously set non-inferiority margin. The third is that the incidence of adverse events, means the number of hypotensions were slightly higher in ARNI, number of the other allergic reactions and cough was higher in Ramipril, but the overall tolerability of ARNI was same as with Ram. The fourth point, if you now with the new statistical formula, if you look at the win ratio of the same trial, then ARNI was definitely superior as compared to this thing. Whether we should sort of go into complex statistics or whether it should be a simple superiority, that's a different discussion altogether. But on these points, when we say, it is like saying that BJP lost because they didn't get 272 and Congress won because they improved from 59 to 100. So it is not that it was exactly the non-inferiority, this thing was met. It was numerically ARNI was superior, and on these counts it was. And it was statistically ARNI was superior if you look at the coronary events. That means deaths due to coronary causes, the coronary revascularization procedures, or ACS events. Then it was statistically superior in the ARNI. So on these counts, I think, and also with our experience, I think ARNI in this situation would be the choice.
All your AMI patients who have come to you with a STEMI, whom you thrombolize, do a primary angioplasty, and their EFs are below, by default you use. So you don't have any spectrum where you probably use an ACE inhibitor at all. Okay, Ritvik, can you just give your comments?
Right. Am I audible?
Yeah, absolutely. Go ahead.
Yeah, fine. So I think continuing what I have left and then adding this question for the discussion, that whatever AC inhibitor trialist we have discussed, if you look at the data, that the early initiation had shown a benefit of around 7%. And if we again extrapolate that data, that the patients with the larger MI, anterior wall MI, with the heart rate of more than 100, hypertensive, higher lip class, they benefit much more than the low risk patients. If we now compare with the recent ARNI and the average duration of initiation of the therapy, which was, I think it is a 4.4 days. So a margin of early initiation, what we call. And in that trialist data also, with those who were started, so the duration was around 36 hours post chest pain, but the most of the benefit which was seen when it was initiated in the first 48 hours. So 4.4 days of mean duration of initiation of ARNI again is a flaw to whatever trial, or that could be one of the contributors. So the answer to the second part, that could be one of the contributors, that the trial failed to show the benefit which was expected. Again, setting up a very higher expectation of 15%, a composite which was again set, that is CV death, then hospitalization for the heart failure, and a third component was a OPD visit for the heart pillow. That was, I think, a third part. And if you add all the three in the composite, sometimes it makes things very difficult to re-evaluate. If you look at the exclusion criteria in the trial, so all the high-risk patients were included, but a diuretic usage, a recent diuretic usage patients were excluded. And now a CLIP class of 3 or more than 2 and patient had a signs of congestion, you must have or someone must have used a diuretics, probably injectable to oral in a transition form. And I think if you would add these high risk category patients, the results would have been different. But of course, ramipril early initiated in those trials versus initiation of an average 4.4 day for of the reason where it showed or failed to show the benefit. And coming to the answer again, if patient is not on any therapy, I'll still be happy with initiating ACE inhibitors or ARB. Uh, Again, going to the fact that even SGLT2 trials also failed to show the same benefits. So the post-MI setup patients are a different category of patients, and intervention, what we do, uh, probably we are doing much better job. We are initiating therapy in a much better way. So sometimes it makes things very difficult for us to actually discriminate or identify a patients. But going back with the robust data we have with ACE inhibitors, I'll be happy to initiate the ACE inhibitors. But of course, on a stable patients, because we are discussing a post-MI patients, I'll be very happy to initiate the same therapy.
Okay.
Dr. Badani, are you asking me?
Your view.
Yeah, sure. So, in a post-MI patient, I don't know, I would go for an ACE inhibitor first, and then look at maybe 30 days how the LV is performing. If the patient is getting into a situation where, despite the post-MI, if in the acute phase, definitely I'll use ACE inhibitor, not an ARNI. For the simple fact, I would prefer it for a bit of chronic ischemic cardiomyopathy patients with reduced ejection fraction. That would be my preference for the ARNI, and that is where the maximal benefit will be, especially for a hypertensive patient. So after a month or so, if I see that the patient has gone into a chronic ischemic cardiomyopathy situation, where in the LV is not improving, LV is struggling, and still the stunning hibernating myocardium is there, then I would definitely switch from an ACE inhibitor to an ARNI as soon as possible. As Dr. Ritik said, SGLT2 inhibitors, there is no data on that. But then for the chronic ischemic cardiomyopathy patients, definitely I would like to go for that. Now, why ARNI has not shown statistically significant reduction? You can use the other point that even there was no statistically significant reduction for the ACE inhibitors also. So you could look at it from the other point of view also. But my take is for the first month in the acute phase, go for the ACE inhibitor immediately. And then once the patient gets into a chronic cardiomyopathy situation where the LV is reduced, I would start using the ARNI.
Okay. So I think obviously different views in terms of somebody uses pure ARNI, somebody really believes ACE and then reevaluate and then go for ARNI. And so, okay, so I think Praveen, if at all, if we look at the trial and say that it was not statistically significant, what could have been the reason why ARNI failed to show superiority over ACE inhibitor in the Paradise MI? What was the primary, but what were the causes that you would have probably thought of that why it did? Because otherwise, Paradigm HF, enalapril versus this thing was a huge benefit and a significant difference. So, any comments on that? You're muted, Praveen.
Both of the speaker have given a comment that, even Dr. Abhyankar told that numerically it was better. My understanding is, the big MI, because there were some non-ST-MI, inferior wall MI 20%. Those type of population where there is not a lot of necrosis, the benefit of ARNI may not be seen. But though numerically ARNI did well, it didn't have tolerance was also good. So I think I take it as a positive thing, because post-MI patient I have to protect from two things. One is a thrombotic event, and second is LV remodeling. Now, when I speak of a thrombotic event, I do know that AC inhibitor are known to reduce thrombotic events by effect on the plasminogen activator. I am not aware whether ARNI has that benefit or not. But now in current era, in contrast to the old trial, which might be using clopidogrel, ticlopidine, now I am using ticagrelor, which gives good protection to as far as thrombotic events are concerned. Now, as far as ARNI is concerned, biochemically, it has a very strong anti-remodeling, and it is definitely superior. And as you have already seen in Paradigm trial. So my understanding from the Paradise MI trial, understanding the two main problem of one is remodeling and second is the thrombotic event and current era of primary PCI, I think that if it's a large MI and if there is an opportunity to give an ARNI, that definitely would be preferred.
Okay. So anybody wants to comment about why ARNI didn't? Because I believe there is another major factor is that your remodeling requires, and basically ARNI really acts at a real anti-fibrotic level, or the remodeling process is at a cellular level quite a bit. And in that also, in the ARNI, your predominant benefit is of the sacubitril rather than the valsartan component. And I think sacubitril takes care of all the impact which probably your ARNI benefits are given. Maybe using this drug in a patient whose necrotic level or maybe the fibrosis level or the impact is not too much, maybe the benefit might not have been statistically significant versus somebody who is what Dr. Manoj was telling is an established chronic heart failure where probably I really require a lot of remodeling. That could have been one of the theoretical possibilities. But yes, point well taken that it is a spectrum of subset of patients that you need to be looking at when you are probably trying to select which one would you wanting to be used. If you have a patient who has a small inferior MI, EF is 45 to 50% or a 40%, which probably you don't know because this EF is just done on day one at the time when you have probably done a revasc or prior to revascularization. After revasc, if these patients really improve, because of the revascularization process itself and the fibrosis is lesser, maybe the benefit of ARNI might not have been as significant or the ACE inhibitor would have been sufficient enough to probably help you. But I think you need to look at this subset of Paradise MI into spectrum wise, an anterior wall MI, large versus small, inferior large versus small, transmural versus subendocardial, ejection fraction in the lower limits versus in the 40s to 45%, that probably might have a lot of impact because you had a spectrum which was very wide. You had taken everybody into picture in the Paradise MI which was there. So I think that could be a possibility. Yeah, Dr. Atul.
Yeah, just to what Praveen was saying, it is somewhat perplexing in the results that the site of infarct actually did not affect the outcome. That means the difference in the outcomes was not different related to the site of infarct, which is somewhat perplexing. But as I said, that it's saying whether the glass is half full or half empty. So I think when you say it is not superior because of the statistical this thing, if you look at the absolute reduction in mortality, absolute reduction, it is 1% reduction in mortality. So I don't think we should say that it did not outperform. Maybe it did not outperform as much as we expected, but it did outperform.
Yeah, so numerically it is fine, but when it comes to a trial, same thing is the Paragon
1%,
HF. Your
1%
Paragon HF.
absolute reduction in mortality.
Yeah. So there is no denial of the fact that the drug did well. That is fine. But finally, what amounts to is your p-value, which probably everybody goes by. Why Paragon HF? Your ARNI versus valsartan was again non-inferior, which was there. It didn't show, but then there was a subset of female patients, EF below 57%, who had a tremendous significant benefit in those subsets. With somehow or the other, here we couldn't segregate that subset ki, baba, as we said, larger MI or non-larger MI. So whatever said and done, you are at level 0. You may tilt to this side or that side, would be your individual choice. But that is one thing very clear, that you did not show the true superiority which you are supposed to show as far as the trial data was concerned. So I absolutely agree that if you are really keen on starting ARNI very early, if a patient is hemodynamically stable and pressure allows you, definitely you would want to take it, no problem. And somebody who wants to use an ACE inhibitor in terms of borderline pressures, high diuretic usage, and you want to really start that drug, probably nothing wrong with that, because at the end of the day, any drug used is going to cause that benefit.
That's precisely what I said in the previous comment, that when you say that somebody starts ACE inhibitor, am I saying it's wrong? No, it's not wrong. But
Absolutely.
I'm only contesting the statement that, that ARNI did not outperform this thing. Yes, in terms of the margin side, yes, but if ACE inhibitor, it doesn't mean that ACE inhibitor is a bad drug in any way, but it is just a matter of how you interpret the statistics.
Absolutely, absolutely. So points well taken. Chalo, next, let's go ahead. Next slide, please. Okay, current guidelines, what do they suggest? Next slide, please. Let's be quick now. So I think the major guidelines post STEMI 2017, ESC, ACCHA 2013, ACE inhibitor was STEMI with anterior location, EF below 40, early heart failure, diabetic and hypertension. Class 1B is ARB for EF below 40. Again, it's mentioned very clearly, intolerant to ACE inhibitor. But again, one point that we need to remember is somebody, I like what Dr. Atul mentioned, is if somebody for hypertension has been on an ARB which is there, let's say valsartan for example, you probably can continue that even though it's a 1B recommendation because of the trials and the data that we are talking. And 2A recommendation is all ACE inhibitors are all STEMI within 24 hours unless contraindicated. Next slide, please. 2023 ESC guidelines of ACS is ACE inhibitors are recommended in ACS with heart failure, EF below 40, diabetic hypertension and or CKD1A. Routine ACE inhibitors for all ACS regardless of EF should be considered. It was a 2A recommendation, ENJ 2023 publication for ACS. Next slide. I think we know very clearly because the moment the data was published with the Paradise MI, probably the ARNI would be taking a backseat because that's only one trial and that too did not really prove that well. 2020 guidelines for ACS is ACE inhibitors or ARB intolerant to ACE are recommended with heart failure with reduced EF that we already know, CKD unless contraindicated in order to reduce all cause and cardiovascular mortality and morbidity class 1A recommendation with beta blockers, MRA and SGLT2 also. Next slide. So now post-MI state of the art, this was probably, I think, a very good publication in 2018 that said that index MI, if it is 0 hours, early initiation of ACE inhibitors within first 24 hours, 40% survival benefit is conferred on the first day. Then avoid beta blockers for first 24 hours if there is an ongoing heart failure. Early introduction of aldosterone antagonist benefit is time dependent, should be started within 7 days of the index MI, and re-evaluate the eligibility of beta blocker therapy throughout hospitalization. And post-discharge, it is critical to titrate the dosage of medications depending on their blood pressure to optimal levels in the post-discharge period. So what does it tell you very clearly is early ACE inhibitor therapy initiation, up titration to maximum recommended dose offers maximum benefit, because we already know that 5 milligram twice a day is the dose which is there. And beta blockers and your other drugs, which is that these are only post-MI heart failure we are talking. We're not talking about the chronic heart failure. Next slide, please. Why are the slides changing too slowly? Okay, Jack acknowledges your AIR, which is the first ramipril study, and it tells you again the same thing. ACE inhibitor should be administered very early, and even beta blocker within 24 hours. High dose beta blocker is harmful, should be avoided in MI and heart failure for high risk cardiogenic shock patients and whose blood pressures are below 120, sinus tachycardia, or more than 110 or less than 60 beats per minute. According to the Capricorn and the Comet CCS2 trial and ACE inhibitor, we have save air and trace already, which we have discussed. Next slide, please. So basically trying to highlight that the earlier you're able to start an ACE inhibitor, the better it is by whatever data we have. Okay, now we will have Dr. Manoj in post-MI, post-revascularization. What systolic BP do you initiate ACE inhibitor? What is the starting dose do you recommend and how do you up-titrate the doses? Very quickly, because we are running short. So we can
Dr.
do it pretty
Rajesh,
quick.
Dr. Rajesh, I think what I would do is just check the systolic blood pressure more than 100. Anything less than 100, it's not indicated, is actually contraindicated because you might actually precipitate and increase your chance of having, the MI to progress. Starting dose, if the pressures are more than 100, 120, I would start with 2.5, see how things are going, and then up titrate as we go ahead with the pressures, in a BD dose, and then escalate to 5 mg BD at the end of maybe towards the discharge time or maybe in the OPD basis. So it's a very gradual upgradation which we need to do. I think that's my take.
So I think that's fine. Rutvik, any change or would you follow the same?
Yeah, I think what he said is perfect. The only thing I add is that apart from hypotension, but a heavy dose of diuretics, I would be slightly slow to start the therapy so that we can prevent AKI in the hyperkalemic index. Otherwise, I think perfect is it.
Perfect. So I think go slow, start low, and maybe up titrate gradually. Even if post discharge you want to follow up your patient opinion, then you want to escalate. That's fine, because I think the main challenge of ACE inhibitor that we need to understand is the first dose hypotension. So in these patients who are already having LV dysfunction, acute MI, be careful using a little moderate or a higher dose to initiate initially. And once they are able to tolerate that, and I think then you can probably escalate it. Next slide, please. Yeah, so I think Dr. Atul and Dr. Praveen, in this subset of patient post-MI, when do you like to start a beta blocker? And which is your preferred beta blocker? At what dose do you initiate? How do you up titrate? And what will you advise an ACE inhibitor beta blocker combination? This is a post-MI, post-revascularization. Imagine we are talking of 24 hours. You've done a plasty and your EF is this. So on that basis, Dr. Atul, you can start and then I think we'll take Praveen.
Yeah, I would probably would want to start the beta blocker at the time of discharge if everything remains stable, because once the revascularization done and all data shows whether it is related to revascularization or not, that early beta blocker actually has a downside. Which beta blocker? I think it's very difficult to make a choice amongst beta blockers, but a significant LV dysfunction, then probably carvedilol would be my choice. I mean, it's hair splitting to say that, why one is superior over the other. But probably looking at all the data, probably I would start low dose of carvedilol and then up titrate from there. But metoprolol or anything is fair enough. There's nothing wrong against that. So whether I would use a combination of ACE inhibitors and beta blockers, probably at the time of discharge. So if the ACE inhibitor is already started, then I would at the time of discharge, unless there is any contraindication. Otherwise, I would start at the time of discharge.
So I think, Praveen, any comments? How do you go about in your subset?
Yeah, my practice is little different. I always use bisoprolol, and I prefer bisoprolol because I think that I reached the fortunately at the end of 1.5 months, I reached the target dose more easily as compared to other beta blockers, and so obviously I don't use the fixed dose combination because none of them currently available with bisoprolol.
Okay. And when do you use your beta blocker? Start it, in fact, post AMI. Do you start on 24, 48 hours, pre-discharge, post-discharge?
Yeah,
How do you learn it?
I start within usually 48 hours.
Okay. So I think the most important thing, I think both of them mentioned very clearly the beta blocker should be used. But again, you have to probably consider that they shouldn't have signs of fluid overload, crepitations not there, not in frank heart failure. Imagine the patient is not in heart failure, heart rate is 90 plus, blood pressure is 120 plus. Probably if you are able to use an ACE inhibitor and a beta blocker at that particular, you can. But if you believe that beta blocker patient is still in failure, fluid overload is there, patient is on very high diuretic dosages, then please reserve beta blocker to at least beyond 48 to this thing. Choice of beta blocker is, as Dr. Atul mentioned, is hair splitting, but point from Praveen that is mentioned is very important, that dosage wise mortality benefit, if you talk of, CBIS 2 was the only trial which showed that smallest dose of beta blocker had a mortality benefit at 1.25 dosage, but with beta blocker and carvedilol, you need to be on 25 BID to show the true 32 or 33% mortality benefit, which was mentioned. And in the merit HF, which was probably around 100 milligram twice a day, which somehow in our clinical practices, we may not be able to use that dosage. Maybe we may not be able to achieve that dosage though. One question to add is to all of you is that imagine a person is a patient whose EF is not really low, let's say 40% to 49 or 50%. How would you, any of you would want to comment is whether beta blocker has any benefits? And if you are going to start a beta blocker, how long are you going to continue it? And what will be your cutoff at which you will stop? And I think the controversy which has come up with the latest publication is beta blocker probably doesn't have a great mortality benefit if it is used beyond a year or so, because in the other data it was 3 years plus. So any comments on that point anybody would like to highlight?
I think what Dr. Abhyankar has already explained, and Arni versus ACE, that there is no benefit. But I don't think that there is a big loss if the beta blocker is continued, especially if patient is hypertensive. So it is not rigorous that we are just withdrawing beta blocker in our clinical practice after 1 year. I think many of our patients do continue on a long term, even if their EF is 40%.
Okay.
Yeah, I think
Any-
that's why the guidelines are always more generalized. But if you're talking of continuing beta blockers, it would depend on the patient subset. If you're talking of a young patient having an anterior MI, more of a thrombus, hardly just a single plaque, then probably, and or an RCA in a young patient, maybe beta blocker will not really have that much benefit. But if you are talking of a person, an aged person, multi-vessel disease, then I think beta blocker continued over a long period of time has definite benefit. So we have to look at a specific patient.
So you're trying to say about maybe the pleiotropic benefits and not the true anti-arrhythmic, and the mortality benefits would also add in those subset of patients.
Yes.
And so that point is absolutely well taken, that you need to be segregating it if your ejection fraction is really good. And I think one important point in all this is please look at the resting heart rate. And with a beta blocker, if your resting heart rate is really going below 60, there is going to be a significant amount of chronotropic incompetence. So many times the fatigue and the tiredness that a person may come, you may be very surprised. It may not be because of heart failure, but because your heart rates are too low. So do not try to get your heart rates below 50s. 50 to 60 is borderline, 60 to 70 acceptable, and above 70, definitely you need to escalate according to what we are talking about. Fine. Next slide, please. Ramipril versus other ACE inhibitors. So wanted to know, yeah, next slide. So I think this study, I think everybody has gone through, and it's a 2004 publication of 7,500 acute MI patients, 30-day post-discharge till 1 year. Enalapril, lisinopril, fosinopril, ramipril, captopril, pinapril, and pendropril in subsect to 30, 30, 12, 12, 6, 4, and 3%. And all patients received standard therapy. Observation they wanted to see was reduction in the mortality with different ACE inhibitors. Next slide, please. So just want to know whether it's a class effect, and next slide. So lowest mortality was observed with ramipril in this particular study though, and patients who filled prescription for ramipril statistically significant lower mortality within the first year after acute MI than obviously with the other ACE inhibitors. Next slide. So I think post-revascularization, if you find LV systolic dysfunction, EF is below 40%, but without clinical heart failure in your patient, will you put the patient? I think this we have discussed, but still quick pointers from Dr. Abhyankar that would you still put the patient on ACE on RNA? I think sir was very clear that even if a patient has LV systolic dysfunction, EF below 40 and not without clinical signs of heart failure. So it's not a true paradigm HF is what I'm trying, what this question is about. So what would you use, sir?
I think in today's world, ARNI in most subsets, because across the spectrum of ejection fraction, it's now proven that it's useful.
Perfect. Praveen, in which scenario will you directly advise ARNI and what is the dose would you usually use?
Yeah, I think we have already spoken that it is a large MI. Maybe if we are speaking of post-MI setting, then it's a large MI and it's coming out of heart failure. Definitely, we do start wherever there is opportunity, which means BP is not like 90 systolic. And the dose usually always 50 milligram BD. I have never broken the tablet because I believe that the the dual molecule is not supposed to be broken, though there are many companies come with 25 milligram. I have never used these lower dosages.
No, so I agree. 50 BID and as you said, larger MI. So basically, even patients who do not have signs of heart failure and LV systolic dysfunction is there, you probably can use an ARNI in the respective dosages depending on the blood pressure post-revascularization. Next slide, please. So I think we are just heading towards 9-8. So I think we have a couple of okay, one quick questions. 55-year-old smoker and diabetic hypertension with elevated LDL but no heart failure or LV systolic dysfunction. Will you opt for ACE inhibitor or ARB? ACE inhibitor evidence by Hope and Europa, ARB on target and transient data. Transient. So Dr. Manoj first and then Dr. Rutvig, your comments, but very quick.
I think I'll ask Dr. Ritwik to comment first.
Yeah.
Thank you. From on target and transit, I think it is clearly mentioned that AC are the drug of choice unless it gets complicated by cough and other stuff. So Hope and Europa has clearly shown the benefit. On target, again, it's not that great. The indications are very limited as per the trials which we have quoted. So ACE inhibitors are the drug of choice in high-risk patients with stable C8.
Yeah,
Okay.
I think I agree with
Yeah.
that. As long as the EGFR is well maintained, I think we should go ahead with the ACE inhibitors.
So high risk subset of cardiovascular risk patients with multiple, like, smoker, diabetic, hypertensive, LDL, but the only thing is no LV dysfunction and no heart failure. Probably yes. By data, you definitely would use. Only challenge which you need to be careful is about your cough, which is there, and tolerability, which is there, and achievement of a dosage. How many of you are able to achieve 5 milligram BID ramipril in your clinical practice versus 80 milligram telmisartan versus let's talk about ARNI 100 milligrams in your clinical practice. Percentage wise, Dr. Abhyankar, how many subsets?
Yeah, I think ARNI 100 milligram twice a day in large number of patients, 200 milligram twice a day in maybe 5 to 10% of patients, and 50 milligram twice a day in all the remaining patients. I mean, majority of patients would tolerate at least that dose, but even 100 milligram is fairly tolerated. Ramipril 5 milligram twice a day, probably in 50% of patients would tolerate. Telmisartan, in my experience, it kind of is very age related. In older population, the incidence of postural hypotension is pretty high at the dose of 80 milligrams. So in younger population, probably most patients would tolerate telmisartan 80 milligram, but in older population, probably only 50%.
Yeah, anybody else wants to say? Because I believe Ramipril 10 milligram is a major challenge and not so much of 80 versus your 100 of army. So that somehow, because by the time maybe you escalate it, maybe the chances of cough also increases. So that is another factor that we need to look into it. But data wise, yes, high risk cardiovascular, very, very good data supporting ACE inhibitor by the HOPE as well as the Europa trial. Next slide, please. Yeah, Praveen.
No, I think those who tolerate 5 mg Ramipril, even they could tolerate 10 mg. Usually, doubling the dose doesn't, have that anti-hypertensive effect. And even I believe once they tolerate a good dose, by increasing cough doesn't increase dramatically.
Yeah, so basically the tolerance is only of the 5. So let's come to the next question only. Is that cough in Paradise MI? We are not. So reported event 13 versus 9, 2.3 versus 1.2. So we just want to discuss 2 points is what is the incidence in your practice for ACE inhibitor? That is part A, and is all cough attributable to ACE inhibitor is point 2. So let's start with Rutvik first.
Cough is around almost 15% of the cases, but if you try to identify the cause, maybe a GERD sometimes plays a vital role. You correct GERD, patient feels better. So 10 to 15% is roughly a number. You initiate the therapy and the patient comes back to you. And I also agree with Dr. Praveen's statement that if you tolerate 5 mg, I think you can up titrate to 10 mg reasonably well. So my experience is around, say, 10 to 15%.
And what do you do if at all it is there? What do you do? What's your next step? You stop it, shift it to some other drug. What do you do normally?
Yeah, see, as I said that again, history part and the patient preferences has to be selected. If the cough is really cumbersome and that's the only complaint patient had, otherwise patient is doing well, I think we have to switch. And if you feel that the patient somehow they'll be able to persuaded by you and they'll able to follow you, I think you can explain to them, try to identify the cause. As I mentioned, the GERD being a cause, and you try to correct it. And if it's corrected, you tell them that it's good drug to continue.
So
So it
initially
depends on the
convince,
patient.
and if not, then change.
Don't work on that part, they'll go to a different consultant for a cup, and then the other will directly identify the cause, and you will be fooled sometimes. So I think aggressive actions are sometimes required depending on the patient and his mindset.
Then Dr. Praveen and then Dr. Manoj. Percentage of cough with ACE.
I think, I think it's almost more or less same experience which other have. With Arni, I don't have many occasional 1 or 2 cases where they had an resistant cough, and then you send to a chest physician and he's also not finding any cause, and then we decide to take off Arni. There are occasional cases, but yes, the experience with ACE inhibitor, whether it is Ramipril or Prenropil, as everybody is saying, at 8 to 10%, 10 to 15% is the experience.
And what do you do? Stop it if at all you have it?
No, we try to continue it. I try to continue and tell the patient that this may be related to the drug, but the benefits are there. But there are few patients who won't tolerate. Then definitely we don't have any option. We have to change to ARV. But yes, there are good patients who had cough, but as you continue, they do tolerate. Cough is related to the drug, or they develop tolerance to drug, or there was some other reason. As we know that cough is attributable to many different scenarios.
So I think you need to look at it. The important part is try to continue, convince the patient, ask him basically, because the drug is much, much more superior in the benefit point of view, still intolerant, then probably you may think about it as a last resort. Dr. Atul, your things, it's exactly same or anything different?
Yeah, I agree. I think half of the people who develop cough need discontinuation.
So that's perfect. Dr. Manoj?
Yeah, I think I'll agree with that.
Okay, so I think cough is absolutely very clear thing. Everybody is experienced, but somehow Arni, we've not really seen so much of cough, and discontinuation again has been pretty less with the cough due to Arni, not any other reason. Okay, next please. So I think we've come to the end. It was a wonderful discussion with all experts about ACE inhibitor, ARNI, ARBs, as well as post-AMI, LV dysfunction, how beta blocker usage is. So I think the take-home messages should be that in post-AMI, LV dysfunction, ACE inhibitors have consistently shown reduction in CV death and all-cause mortality with saved RES, ISIS-4, GC3, and CCS1. In this scenario, ACE inhibitors seem to have a class effect. However, there is data to suggest that ramipril will be the preferred ACE inhibitors in the elderly. Paradise MI was the first and only clinical trial for ARNI, did not outperform ramipril with a few exclamation marks in acute MI patients. Ramipril 10 mg per day is the dose which offers the maximum benefit. AIR and Paradise used 5 mg BID and hence maximum benefit were noted in those group of patients. And I think we need to be very, very clear that at least a RAS inhibitor should be initiated immediately post AMI in all these subsets that we talk about. The earlier you use it, better it is. ACE versus ARNI will depend on your subset selectively, which is there. But one thing is very clear that beyond the post-acute phase of an AMI-LV dysfunction, which is generally 6 to 8 weeks period, that is the time when please do an ejection fraction. And if your patient is EF below 40%, he directly converts Paradise MI to a paradigm HF subset of patient. And that patient, at least, you should straight away shift him from an ACE inhibitor to ARNI, which is absolutely non-controversial. The discussion is only in the initial 6 weeks from day 1 to day 40, what I'm going to use. And I think we've had a pretty healthy discussion. And I think it should be a clinical discretion, individual choices, tolerability, and multiple other factors which play a role. So I really thank all the panelists. There have been excellent inputs from all, great learning. Thanks, Dr. Atul, Dr. Praveen, Dr. Rutvik, and Dr. Manoj. And thanks, Anup and EMCURE for the opportunity. I think over to you. I think it was a healthy discussion. We are, I think, 4 or 5 minutes beyond time, 10 minutes rather to exercise.
Yes, sir. I think
Yes.
we have already overshot the time, sir. And I am sure that on the Saturday evening, we have stretched a little more. And I think we had a wonderful discussion on all the topics. Definitely, I mean, we have all the drugs in our portfolio, but it is the right patient, getting the right drug is what matters the most. And that is where, your experiences definitely will help the younger cardiologist who would have joined today and definitely got various valuable insights. So from the team EMCURE, I would thank all of you for providing us with this opportunity, and definitely would look forward for more such valuable discussions in the near future as well. Thank you, sir, and thanks to all the experts, and a very good night.
Thank you. Bye-bye.
Thank you very much.
Bye,
Bye-bye.
sir.
Thanks.
Thank you so much.
Bye, sir.
Ankit, I think we can stop the live session.
Recording stopped.
Thanks. So Ashish, I think काफी सही था यार. So overall, I think we did well. Close to 350.